Okay, I think we've got a few people joining now. I think we'll make a start. Good evening, everybody. My name is Shareef Mahdi. I'm the Honorary Secretary of the RU Group. I'm pleased to welcome you all to the fifth series of the August Seminole 6. I'm pleased to welcome Professor Nick Maynard, who will be talking to us today about the contemporary management of esophageal perforation. The talk will run for about half an hour, and there'll be some time at the end for some Q&As. Just to say that the chat function is disabled, but there is a Q&A function where you can post your questions, and I'll be moderating the session today. So without further ado, I'd like to introduce Professor Maynard, who is a consultant upper GI surgeon based in Oxford and an honorary professor at the University of Oxford. He served as the president of August from 2021 to 2023, and he's known for his work in Gaza as a humanitarian surgeon and was recently awarded a humanitarian medal by King Charles for this. So thank you.
Thank you, Shareef. Thank you for the introduction and thank you for asking me to talk. I've been an upper GI surgeon in Oxford for nearly 29 years now, and I'm going to talk about esophageal perforation and contemporary management. I'm going to talk about the general principles of how to manage esophageal perforation, different interventional options, but a large part of the talk will centered around endoscopic vacuum therapy, as I think this has really transformed the way we can treat esophageal perforations. I'm going to have a couple of case presentations and then talk about the indications and how to progress with this. This is a paper from about 10 years ago that Shiraz Markar wrote looking at esophageal perforations. And at that time, and the incidence has stayed about the same, about 200 cases per annum, with historically a high mortality as seen. On the right, you can see that the outcome has improved over years, both 30-day and 90-day mortality. And clearly, as you can see from the bottom right-hand corner, if it is centralized in areas where they treat more of it, then the outcomes are better. And that stands to reason, like the volume outcome relationships from many diseases and treatments. Iatrogenic trauma is an obvious cause of esophageal perforation in the vast majority, a much lower morbidity and mortality rate. It's very rare with diagnostic endoscopy, but as you go through the various therapeutic interventions, the incidence increases with a maximum incidence of about 6% with esophageal tumours. You can get esophageal perforation from hiatal surgery, very rarely from other surgeries, but hiatal surgery is the most common. And of course, there's non-iatrogenic trauma, fishbone, other bones, penetrating blunt trauma, very rare in this country, but you do see it in other areas. But of course, spontaneous, otherwise known as Boerhaave's, and of course, there's a barogenic trauma injury, which I'm going to talk predominantly about, and we see that quite commonly. We don't see many caustic injuries in this country, but elsewhere in the world, it's extremely common. Boerhaave's, I won't read out the whole description, but it is a wonderful description of what happens. The autopsy showed the strong odor of roast duck and olive oil floating in the pleural cavity. It's a spontaneous rupture, but it's a barogenic trauma with a closed mouth usually and forced vomiting. It causes a longitudinal tear, the vast majority at the left on the left posterolateral wall, low down, less commonly right middle third of the esophagus, and they're commonest in the men. The classical triad, Mackler's triad, is of pain, vomiting, and surgical emphysema. So they do often get surgical emphysema, a lot of pain, respiratory compromise, they're clearly septic, and often a very delayed diagnosis because people don't think of it. Chest X-ray will often give very telltale signs, but the definitive investigations are CT scan with oral and IV contrast. Sometimes you might do a contrast swallow, and of course endoscopy is very useful. And although there was a traditional reluctance to do endoscopy if suspicious of a perforation, actually a low pressure endoscopy is often mandatory and very helpful indeed, and should be done if there's any doubt about the diagnosis. The management of an esophageal perforation is really like the principles are the same as treating any perforated viscus. Resuscitation, treat the sepsis, get good drainage of any collections, control the ongoing leakage, treatment of the lung injury, which they often have with an esophageal perforation, think about nutrition, and create the optimum environment for the esophagus to heal. And I'm going to go through all those different stages. I put down here the treatment, the general principles, diagnose as early as possible. It is remarkable how often this is diagnosed late. Even when you've got a chest drain draining GI tract content, sometimes people are slow to think of it. So it is important to educate all your colleagues and other specialties about the possibilities of this. I think that they should be at the very least discussed, if not transferred, to specialist centres where they deal with these on a regular basis. So certainly discuss it with your local esophagogastric centre. Very occasionally, remote management may well be appropriate, but that is with discussion with the specialist centre. And I think the most important thing is to stratify the patients very early on to non-operative or operative management. You've got to think about how you're going to best decontaminate the field, either surgically or radiologically, management of the sepsis, and of course, early nutrition. I think the very important factors determining how you're going to treat it and indeed the prognosis is the time elapsed between the perforation and diagnosis. Broadly speaking, if you get there within 12 hours of the diagnosis and it's a Boerhaave's, then that is a time when the conditions are optimum for a primary repair if you're going to operate on them. The other important factor is whether the perforation is contained within the mediastinum or is ruptured into the pleural cavity, which is, of course, the majority. Whether other pathology is present, like a cancer, like a stricture, and obviously how sick the patient is. And the three broad groups of treatment will be surgical treatment, endotherapy, which I'm going to concentrate on, and the select number that can be treated conservatively. Conservative management can be done. Clearly, if it's not a full thickness perforation, then that is entirely reasonable. But even if it's full thickness, if there's no significant contamination, the obvious one that falls into that category are the endoscopic or iatrogenic surgical perforations. The vast majority of endoscopic perforations, because they have got an empty stomach and an empty esophagus, there's often minimal contamination, and the majority of those can be treated conservatively. That would require a nasogastric tube, nil by mouth, IV fluids, IV antibiotics, IV proton pump inhibitors, nutritional support, whether that's TPN, a nasoenteric tube, or sometimes a surgical jejunostomy, and then serial contrast swallows weekly for healing. It's important they're not sick, they're not overtly septic. So you've got to be very careful in how you choose these patients, but these sort of patients can be treated conservatively. If you do need to intervene, then you need to think about what you're trying to achieve. Control of the leak, very important. Eradication of sepsis, facilitate re-expansion of the lung, which often is not as easy as you think. Prevention of reflux back from the stomach up into the esophagus, nutritional support, ventilatory support, appropriate antibiotics, including antifungals, and then there will be residual septic foci, which will need targeted drainage at various intervals. What are the surgical options? Again, we operate on less than we used to, but some of them still do need surgery. You can obviously approach it through the right chest, whether it's open or thoracoscopically, left chest, open or thoracoscopically, with or without a laparotomy and a laparoscopy. And of course, since many of these are in the lowest bit of the esophagus, sometimes you can approach these entirely from below, open up the hiatus, repair from below, and lavage the lower pleural cavities on both sides if you need to, all from below. And we not infrequently do that. It's very important to get rid of all the sepsis. And if they've got a big rupture and they've got a large meal in their chest, then you need to make sure you can get all of that out. If it's less than 12 hours, you can usually carry out a primary repair. If it's more than 24 hours, you virtually never can. And if it's between 12 and 24 hours, you sometimes can, depending on the tissues. So you can do a primary repair. You might reinforce the repair with some diaphragm, occasionally with a bit of pleura, if it's very low down with some omentum as well. But if there's any doubt, we would often repair around a T tube. And it's very important to use a big T tube for that, at least 8 millimeters in size. Most of your hospitals won't have that. So it's very important to make sure they do have them available. Because if you ask for a T tube and they give you a 3 or 4 millimeter one, it's utterly useless that. So a big T tube. Very occasionally, you will resect the esophagus. Very rarely, if you do that, you'd reconstruct them primarily. But if you do an esophagectomy, you'd more than likely, if they're septic, bring out a cervical esophagostomy and then do a delayed reconstruction. Consider feeding tubes, venting gastrostomy, and treatment of the distal stricture. For example, if it's an achalasia perforation with a balloon, then you might consider, when you do the repair, doing a contralateral cardiomyotomy. And occasionally you might stent these things. Very briefly, other pathology, caustic strictures, again, rare in this country, but we do see some, very, very common in other countries. When I spent some time in Cape Town in South Africa, they had a huge number of people coming in with caustic injuries. Again, if the esophagus is perforated, then you will end up resecting that esophagus. It's very, you wouldn't primarily reconstruct. You'd bring out an esophagostomy and do a delayed reconstruction. A spontaneous perforation or an iatrogenic perforation of cancer, the conventional thinking is that that makes it into a T4 advanced tumor. But occasionally, if it's confined to the mediastinum, you might consider resecting it. And we've certainly resected a few over the years in Oxford, but they're the exception rather than the rule. And because almost always, if you've perforated, you've converted it into an advanced cancer, often the best treatment for that is a covered self-expanding metal stent. So I'm going to talk predominantly about endoscopic therapy because I think that's the big development in recent years. Endoscopy is very important to make the diagnosis and then to plan whether you're going to treat it conservatively, endoscopically, or operatively. And the vast majority of these we do endoscope. You can, if it's a very small mucosal perforation, particularly if it's just bleeding and not full thickness, you can clip it. We do use stents occasionally, but mainly, in my view, for perforated cancers. Endoscopic vacuum therapy, endovac, esosponge, and stents I'm going to talk mainly about. And of course, you can use an endoscopy to get a tube for feeding and for drainage. And if it's a caustic injury, sometimes just leaving a fine bore tube to maintain luminal patency because it will stricture down further and further. I put this photo in to say that I personally do not like stents at all for benign perforations. This is a stent. This stent is a patient I managed, but who died probably 20 odd years ago. That is an esophageal stent, and that photograph is taken at bronchoscopy. It had been put in for a benign stricture elsewhere, and that is the stent which had eroded through into the trachea, and this patient died. Just because you can stent benign perforations, it doesn't mean you should. And I think our view in Oxford is that it is very, very rarely indicated. There are some people use it for anastomotic leaks. Again, we don't really believe in it for anastomotic leaks. And I think on that slide, you can see the complications, the mortality rates. It's possible to do it, but it doesn't mean it should be done. And our advice is its main indications for a perforated malignant stricture and shouldn't be used in other settings. Now, the exception to that, of course, is the development of the vacuum stent, which we haven't used. I'm not sure yet whether anyone's using it in Oxford. They certainly use them a lot in Amsterdam, and we've heard from them about how they use them. This is obviously the same principle as an endosponge, esosponge, but with a lumen, which enables them to drink through it. I think they are using them quite a lot now in Amsterdam, I know. I don't have any experience, so I won't say much more than them, other than It's a technology which is developing and may be more commonly used in the future. So the bulk of this talk is going to be the general principles of endoscopic vacuum therapy. The principle of it is that you use a tube on a nasogastric tube with a sponge attached to the end of it, which goes within a defect or across a defect, and attach to constant negative pressure therapy. It's exactly the same principle as a vac dressing. It has a permanent negative pressure. It drains infection, it controls leakage, it promotes healing, and it reduces the size of the defect in the cavity. They do often, it's a very labor intensive technique. They leave regular endoscopies to change them. At the endoscopy, you can drain a lot of sepsis through the hole, and often mediastinal washouts via the endoscope is a core part of this. There are two phases really: initial sepsis control, and then subsequent granulation, healing, and closure of the perforation. As you can see on the left, on the right rather, these were originally described predominantly to be used inside the cavity. So the sponge is put in the cavity, a negative pressure is applied. You change it every 3 or 4 days. On the left, is when it's just placed in the lumen across the defect, and increasingly we use more of the intraluminal than the intracavity sponges. So source control, control of leakage, healing and granulation, and closure of defect. And the process, as we do an endoscopy, we wash out, debride the cavity with the endoscope, and then place the device. I'm going to talk about how we place it. If there's a decent sized cavity, then place into the cavity, extraluminal. If there's not a big cavity, or the defect is small, or there's minimal contamination, place in the lumen. And this is a technique we use by far away in the majority when we use it for anastomotic leaks. Attached to a vac pump at 125 millimeters of mercury. Consider how you're going to get gastric drainage and feeding access. We would often put in a drainage gastrostomy and a feeding jejunostomy, and then you take them back to theatre regularly every 3 to 4 days if extraluminal, less frequently if it's intraluminal, and then and often, and you can take sometimes 2 or 3, sometimes even 20 changes if it's a really big cavity. But it's quite remarkable how these cavities can shrink. So this is what the ready-made kit. There are two broad ways of doing it. This is ESO sponge, which we use. We also use the Heath Robinson make it your own kit in Oxford, and I'll come on to that in a minute. But there's an over tube you can see in the middle. There's a pusher, which is the green thing, and then there's a sponge connected to the nasogastric tube, which is introduced through the over tube. So what you do is you do an endoscopy initially to assess the defects, assess the cavity, wash it out if you need to. An extensive lavage into the cavity is often very, very helpful indeed. Decide whether you're going to go intraluminal, whether you're going to go intracavity. If put in an over tube, take the scope out. So you've got the over tube in position with the end of the over tube beyond the defect. Put the sponge through that using the pusher. Endoscope is removed. The over tube's removed, and then you pull it back under endoscopic control to make sure it's in the right place. If it's clearly going into the cavity, then your over tube will have gone into the cavity, again under endoscopic control. This is one that one of my colleagues in Oxford, Jeff Roberts, to whom I should say thank you actually, because he's lent me some of these slides. He did a lot of this in Cambridge when he was a senior fellow there, and uses the sort of the homemade kit, which is when you get a bit of sponge from a vac dressing and suture it to the nasogastric tube, as you can see then. These are Jeff's figures from about more than a year ago, and again he's given me permission to share these figures. This was his initial series of 39 patients, 20 iatrogenic, 19 Boerhaaves, 30 successful and 35 patients. The median number of endovac changes 8, mortality 13%, and 1 late esophageal stricture. So pretty good results in what is a very, very comorbid population. And this is just a couple of examples I'll take you through. This was a 63-year-old man with a classical history of Boerhaave's, and endoscopy showed a small defect, but with significant contamination. That's his CT scan. He had perforation of both mediastinal pleura. So he had bilateral chest drains, feeding jejunostomy, and he was extubated, and no other treatment had been instituted at that time because they thought he was quite well. He then became very septic, developed worsening respiratory failure. That's his CT scan. Endoscopy at that point. Now, I'm going to try and get this working. This is the endoscopy, which showed a very large cavity, a lot of necrotic tissue, a much bigger defect than had been appreciated at the first endoscopy. So this is outside the esophagus. This is the mediastinal and pleural cavity. And so Jeff put in an extraluminal end vac placed alongside. There was a luminal one in there. So that's that. That's the cavity taken with static photographs, a huge cavity in the mediastinum. At endoscopy, he had another endoscopy to change it. There was still a big cavity. He had a big cavity washout then, as you can see there. So that's all outside the esophagus, just with the endoscope, irrigating, sucking out. And you can do a lot of debridement and lavage that way. Endosponge placed into the cavity. You can see that going through the cavity, the scope coming out, and then the negative pressure being applied under direct vision, as you can see. And you can see how things were collapsing down. Further CT scan showed a sort of dumbbell type abscess. That was no way that could be drained percutaneously. So at another endoscopy, the endoscope went through into that dumbbell shaped abscess, drained that really well, and another esosponge placed in. So you can see that going in, sucking it all out. So you can really do quite extensive lavage. And this is just serial pictures showing the cavity granulating up, getting smaller and smaller each successive change. But we're talking about 5, 6, 7 weeks here. Day 49, pinhole defect, drinking, and went home soon after that. So this clearly has a very big role in treating perforated esophagus. Generally speaking, lower surgical morbidity as long as you can get good drainage and eradication of sepsis. It is very labour intensive, recurrent washouts. You can, of course, drain internally through the endoscopy. Obviously, with surgery, you might get a more thorough washout and they're not returning to theatre repeatedly. And of course, if it's very early on, you can do a primary repair. So what are the indications? Esophageal defects, essentially from the cricopharyngeus down to the esophagogastric junction. I know Jeff has been using it in the duodenum in some patients as well. Big role to play in anastomotic leaks. I think it's transformed our management of anastomotic leaks. It really has. And of course, in the more unusual positions, as I've described there. I think we are still fair to say defining the exact role. I don't think there's any doubt that we in Oxford, and I'm sure in other units, have treated some holes with esosponge when it wasn't really necessary. So, for example, treating iatrogenic endoscopic perforation, which probably didn't need any treatment at all and would have healed very, very rapidly. So we're still defining the exact role. It's like to develop these guidelines, and we failed to do so. But I think we do. We've got a lot of experience in quite a few centres now. We need to put that together to come up with some clear guidelines as when to use it and how to use it. There are clearly some risks with it, bleeding risks, particularly if they've got varices, although that would be a rarity. If you're going into the abdomen, if they've got chronic pancreatitis, it is close to the airway. There is a risk of fistulae. I've certainly had one fistula, not from a central airway, but from a peripheral airway, which cause a lot of problems. And of course, if it's in the abdomen, there may be a risk of a small bowel enterocute and a fistula. It has got a very clear place in the treatment algorithm. We just don't know precisely where that is at the moment. And there is still a role for surgical repair, whether you do thoracotomy or thoracoscopy. If it's an early presentation and you may get away with a primary repair, there is still a role for that, undoubtedly. But more and more, these patients can be treated with endovac. So the core parts, just to recap before I finish: resuscitation, treatment of sepsis, drainage collections, recurrent endoscopic washouts, control of ongoing leakage. This can all be done in ITU if necessary, or in theatres. Repeated endoscopy to lavage, clearly treat the lung injury, nutrition, genostomies we talked about, and watch the esophagus heal in front of you. It is undoubtedly a very useful option and a very useful tool, which is gradually transforming the way we manage anastomotic leaks and managing other esophageal perforations. I think the VAC stent will clearly have a role to play. Again, where that is used as opposed to the ESO sponge is unclear at the moment, but it clearly will have a role. And I think many centres are now getting very excellent results. It is very labour intensive. These patients often need to go back to theatre twice a week for several weeks. And of course, they do need proper critical care support. You will still need the help from interventional radiology, and always think about nutrition as well. That is about 28 minutes. So I'm going to leave it there, and I'm very happy to take any questions.
Perfect. Thank you for that. That was fantastic run through the contemporary management of esophageal perforations. Learned a lot myself, which is useful for exams. I can't see any questions at the moment in the Q&A. A few people have joined sort of after you started and might have missed the bit where I said that the chat function is not working. So if you've got any questions, please pop them onto the Q&A bit and we'll run them through. In the meantime, I've got a question.
Yeah,
Right. So you talked about guidelines and how we, as a sort of UK-based upper GI community, don't really have any specific guidelines for the use of endovac therapy. Would a UK-wide registry be something that would be helpful here?
definitely. I think we need two things. I think we need a registry, that costs money, but a registry and guidelines. I think it'd be so useful because when we first started using it, I mean, I used the Heath Robinson thing years ago, and then I had a really horrible problem with a airway fistula, and I sort of got very put off using it again. And then my great colleague Bruno started using a lot and got a huge amount of experience. And I think as a group, we probably overused it in some situations, but it I've had anastomotic leaks, I've had holes in the esophagus which have been transformed by this usage. So I'm quite convinced it's got a massive role to play. I just think we need to, we're not good at introducing anything in our profession, unfortunately, because we all get very excited by a new technique and then use it for everything. And we need to learn from there's enough experience now around the country that we need to learn from everyone's experiences, have a registry, record, see what the indications, what the complications are, so we can then work out where its true role is.
Suppose this is a lot of variation perhaps between different units as well in their indication. So that would help highlight that.
Absolutely. Loads of variations.
So I've got some questions on the Q&A box, which is great. So starting off, we've got a question on the alternatives to using an 8 mm T-tube if you haven't got any on your site. What would you suggest?
Bigger one if you've got a bigger one, which you won't have. I mean, there is a 10 mm one, which I've used. Listen, I think use a smaller one. I mean, it won't drain in the way that you want a T-tube to drain, but it will still facilitate drainage along that track and help with the track. So I think I'd still put a T-tube in. It won't work as well as a bigger T-tube, but I think there is still some advantage putting any form of T-tube there because it'll just provide a track for the ongoing leakage to go down. So it ends up you still get better control of the leakage than if you simply did if you did a primary repair, 18 hours after the injury, it's very, very likely to leak. So you should assume it's going to leak and therefore provide an easy way for that leakage to get out. But if you have a really big T tube, then it's entirely possible that it'll function like a T tube's meant to, so the contents go through the lumen of the T tube.
Yeah. Perfect. The next question we've got is about the size of the. Oh, no, hang on. Sorry. What is the incidence of strictures or fibrosis secondary to healing with the endosponge, and do they need subsequent dilatation?
Yeah, I mean, I don't think we really know the answer to that. I think in Jeff's series and in our experience in Oxford, it's a low incidence. It depends how big the how big the defect is, of course. There'll always be some narrowing, but for obvious reasons, would be profoundly reluctant to dilate that maybe until many, many months later. We haven't seen that many strictures in Oxford. I don't think any of us know what the true incidence is, but I guess it will be related to the size of the defect.
Yeah, that makes sense. Um, and then apart from the size of the cavity, when would you prefer intracavity versus intraluminal sponge?
I think increasingly we're using more and more intraluminal sponges. I think the maturity of the cavity, I think if it's a fresh perforation when there hasn't really been a huge cavity formed, I'd never use a intracavity one. So I would restrict it for big cavities, but very mature ones. When you put the scope through, you can see a sort of a well walled off cavity. So that would be the ideal one to use. But of course, most people you're going to be getting in there much earlier than that. So in most of these people, one would hope there won't be a really mature cavity. And since we're using them more and more for anastomotic leaks, you would hopefully never have a well-formed cavity by the time you endoscope those patients. So most of those we use intraluminal now.
Fair enough. So questions are coming in, which is great. We keep them coming. So the next one is I've got yes, a question on whether a surgical gastrostomy is always needed when an NG tube can be inserted.
Yeah, so it's a really good question that. I mean, you can put a nasogastric tube beyond the nasogastric tube with the ESO sponge attached to it. It's clearly not going into the stomach, and so you're still going to get some reflux back up. Um, Increasingly now, we don't put anything in the stomach if we're just going to use an ESO sponge. But if we're going to feed them enterally through a surgical feeding jejunostomy, we would nearly always put a gastrostomy in then at the same time. But but we now would rarely put a do a operate to put a drainage gastrostomy in just for that purpose because you will get control of any refluxate coming up from the tube from
Yeah,
the ESO sponge.
yeah, yeah. Um, and then the next question is, when would you recommend a primary repair of the esophagus versus insertion of a T-tube, which is a quite a common question, I think, in
Yeah.
exam.
So, I mean, my rule of thumb that has worked reasonably well over the years is less than 12 hours. The most important thing is what the tissues look like at the time of surgery, is the bottom line. And that, but if it's less than 12 hours, you can usually carry out a primary repair. But I've done some in less than 12 hours where the tissues have been really manky and therefore you can't. And I have done primary repairs at 18 hours. But as a general rule of thumb, it's two things: the timing, less than 12 hours, and then what the tissues look like.
Yeah,
And I think I mean, I think also the mechanism of injury. So, if it's an iatrogenic one, again, you wouldn't normally have to repair an iatrogenic, but if you've got a very big iatrogenic one, so for example, from an achalasia dilatation,
mm,
then when you know there's no contamination, and then it's very, very likely you'll get away with the primary repair then. I did one when someone swallowed a razor blade and it cut a 10 centimeter perforation in the esophagus, and that was just easy to do a primary repair because it was so early. But basically, how long time interval between the damage and the operation, the mode of injury, and the state of the tissues, and how ill the patient is. I mean, clearly, if they're profoundly septic, it's unlikely you're going to do primary repair.
Fair enough. And just a question for me, just related to that. When you mentioned sort of the use of reinforcement flaps and things, I think so. When would you use that?
Yeah, I
Uh,
mean, this is what the books say. So I've never used a mentum. I have used a mentum when I've tackled it from below, actually. I've used pleural repair once, but I was just because I'd read about it and someone had talked about it, and I thought it was pretty useless, actually. Um, Intercostal muscle I've used as well. So these things are all available to you, but I personally wouldn't do any of those things routinely. I would just do a primary repair or T-tube repair. But I mean, those options are available to you. I just haven't found from a practical point of view them particularly useful.
yeah, yeah. The next question is relevant to feeding, which is obviously an important part of the management of esophageal perforation, and asks whether you would prefer using surgical jejunostomy feeding or TPN.
A good question. I think it depends how long you think it's going to take for that to heal. Now, of course, you don't always know that. If it's a clean iatrogenic perforation, then I would almost certainly use TPN. I wouldn't put them through a feeding jejunostomy. If they've got a big perforation or they're septic or and you think it's going to take a long time, then I'd put in the feeding jejunostomy because it's much better for them in the long run to have enteral nutrition. So I think it'd be determined on how long it's going to take to heal.
Yeah.
Certainly, if you're treating conservatively, then I would often just feed them with TPN because in those you would expect it to heal fairly quickly.
Um, While we're waiting for some more questions, we've got a bit of time. I had a query. You mentioned sort of minimally invasive techniques, and I wondered, obviously, that would be another area where there's quite a lot of variation, I suppose, around the country. Do we need some some prospective data to sort of understand, compare open repair, primary repair versus minimally invasive repair, and understand the outcomes? Do you have any experience of that locally?
No, I've certainly not done any minute. I think Bruno's done a couple, I think. Um, I mean, I don't think you're going to ever going to get any sort of randomized data to tell you which is best used. But I think I don't see the point of doing randomized. I think you've got to think about what are you trying to achieve? You've got to
Mm,
achieve control of sepsis, eradication of sepsis, control of ongoing sepsis, repair of tissues. If you've got, you know, a meal of roast duck and gravy and potatoes and cabbage in your chest. Yeah, I think you're going to struggle to get that all out with a thoracoscope, is my view, and therefore that usually need. And I mean, literally, you're putting your hand in and scooping this food out. They're rare, of course, but you see. So by all means do something thoracoscopically, but you've got to be sure you can get really, really good lavage, get everything out. And you've got to be sure you can repair it properly. If you can do both those things, then absolutely do it thoracoscopically.
mm, mm. Fair enough. And just in relation to the repair, one of the attendees has got a question about where you put your chest drains. Do you put a drain next to the hole? Do you put a basal and apical one? Is it two, three drains? What do
Yeah,
you?
yeah. Again, good. I'd always put one lying alongside the hole. Sometimes even two along there. And I'd always put a basal one in. I'd usually put an apical one in, but then I'd take that one out pretty rapidly once the lung had expanded.
Yeah, yeah, that makes sense. And just you mentioned sort of your in patients who've got sort of a massive contamination, a big perforation, and sometimes you do a primary resection, but wouldn't anastomose and bring out esophagostomy. How common is that? Is that something, have you ever anastomosed primarily? Uh,
I've done it. I've anast. So doing an esophagectomy is very, very rare. I mean, I've done two or three, I think, in my career. Um, Two of them were for caustic injuries, and I think, one was a Boerhaave.
yeah,
I've also resected about three or four cancers after they've perforated, but they've been in. really good condition, minimal contamination. They were iatrogenic perforations, so I've resected them straight away and I've reconstructed straight away, albeit I've made sure I've gone up into the neck for the anastomosis. Um, it's rare that most of these people you won't be resecting. So I'm certainly not saying it's standard treatment, but I have resected and reconstructed. But the ones that I've resected because they're so sick and the esophagus is so damaged, I mean, they are really sick people. You'd be utterly mad to reconstruct under those circumstances, in my view. And therefore, what I do in those, I mean, some in a couple of them, I've just literally done damage limitation esophagectomy, not even gone to the neck or the abdomen, just stapled at the thoracic inlet, stapled at the hiatus, get them to ITU, resuscitate, and then bring them back a day or two later for a cervical esophagostomy, a gastrostomy, and a feeding jejunostomy.
Mm.
And then you reconstruct them, in through the anterior mediastinum 6 months, maybe even a year later.
Um, we've got a question. I think yes, it's mentioning in of the two esophageal cancer perforations that you've resected and reconstructed. Did they have a recurrence of their cancers, or were they cured?
I've certainly had one long-term cure. I think I might have done more than two resections. I can't quite remember. The one I remember, it was a long-term cure, and I remember her very well indeed. And I certainly remember one coming back fairly quickly. So it was, we gave them adjuvant radiotherapy for obvious reasons. But I've certainly had one long-term cure.
Fair enough. Um, while we've got a few minutes, I thought I'd ask a controversial question. So you mentioned your sort of dislike for stents in benign disease. Do Is there any strong evidence for why some people do use stents?
Yeah, because they can. So I'm going to qualify what I say because I think now, of course, we have removable stents, and of course, I use removable stents in benign disease, and we have these absorbable stents. We haven't used them, although we're about to use one of those. So my statement about never use stents is permanent stents.
Mm.
There's clearly good rationale for using removable stents or absorbable stents, but permanent stents, I would never use in benign disease. I I don't particularly like using stents in anastomotic leaks. Although I'm fully aware that a lot of people do use them. I've just never quite understood how they work. And I think I've given a separate talk on this, and I'm very clear. The literature is very clear on this. Is that it does enable you to perhaps drink earlier than otherwise, but there's no real evidence that it promotes healing any quicker than conservative management. So, but listen, this is we're not talking about anastomotic leaks now. That's another discussion. We don't use them, but stents in benign disease are dangerous unless you can take them out after. So when we put in a removable stent, we would routinely remove it after 6 to 8 weeks.
Yeah. And do you use them for removable stents for Boerhaave's for some patients who may be frail and not necessarily?
No, because and again, one of the reasons I don't really like stents in anastomotic leaks is I don't think stents work very well unless there's a stricture to grip it. So with the Boerhaave's, you won't have a stricture. So I don't personally see how a stent is going to get a really, really good seal. I mean, I've seen quite a lot of people who've had stents put in for good reasons, and if the top of the stent is floating in the middle of the lumen and stuff goes down out either side, the outside. Now I know you can clip the top of the stent, you can suture the top of the stent to the mucosa, and I completely accept people do that and say that it works very well, and I have to accept that. We just don't do it in our unit. And I think now we've got ESOS, endovac treatment. I just don't see the need. But maybe the vac stent will transform and change my mind.
Let's see. Well, that's a good place to, I think, end. That's been a fantastic last 45 minutes. Thank you very much, Nick, for that.
Well,
Um,
thank you.
And thank you for all the questions from everybody. Just before we end, I just wanted to highlight our next and final Seminole 6 series for this year will be on the 17th of December with Professor Chris Menon and Cameron Fairfield. And Prof Menon will be talking about the evidence-based management of HCC. So look forward to seeing all of you then, and we'll have further series next year, which the dates for which will be published soon. Thank you very much and have a good evening.
Thank you, Shareef.